Okay.
Yeah, that was awesome.
So we'll try it again. So we talked about the endocrine, right? So what we're actually going to kind of talk about is the pituitary. What's the pituitary gland? Okay. And what's it do?
It secretes oxytocin and ADH in the posterior, and the anterior secretes like ones that go to other organs.
Yeah.
So.
Right. It's kind of what's called the master gland. So it's the one that kind of regulates all the other glands. Now it actually has a master itself, which we'll talk about. Right. Parathyroid and thyroid drugs. So where's your thyroid and parathyroid? Right. So here in the neck. Right. Excellent. Okay. Right. And so those kind of regulate the thyroid stuff. Does kind of metabolism. Okay.
Body temperature?
Mm-hmm. Absolutely. Yep. Okay. So your adrenals.
On top of your kidney.
Top of your kidneys, and they do what?
Epinephrine.
Okay, yeah, so epi, norepi. Is that what you said? Okay, what else?
Aldosterone too, right?
Okay, yep. So mineralocorticoids, glucocorticoids. Okay, good. Your pancreatic drugs, so pancreas. So what's your pancreas do?
Insulin.
Okay.
And glucagon.
Insulin, glucagon. Good, yep. And then basically we'll get into the reproductive sexual behavior medications. Alrighty? And you guys kind of said this, right? The whole purpose of this, of the endocrine system, is to regulate systems and to basically control, which is kind of similar, right? So regulate basically kind of means we want to keep it within certain parameters. Control is we're going to kind of direct them in which path we want to go. Right? All right. So now the glands overall have exocrine and endocrine functions. Some have both. Some are strictly go kind of the other way. All right. So exocrine basically secretes enzymes out. Right? So basically, the terminal portion of this is basically close to an organ. It secretes the enzyme. The enzyme does what it's supposed to do within that neurojunction, and then goes on. Okay? So exocrine basically is out. So can you give me an example of an exocrine function of a gland?
Like mammary glands and milk.
Okay, yep. That'll work. Okay, so the pancreas has exocrine functions. So basically the amylase and lipase and the enzymes that basically it releases so that the food can get broken down. Those are exocrine functions. Okay. Endocrine basically is hormones. These are transported through the bloodstream and basically have receptors, right? So exocrine is basically very close. Endocrine basically goes systemically and causes an effect. So can you give me an example of an endocrine function? Okay. Good. Does that make sense? Okay. All right. So, and y'all have seen this slide before, so you should be able to tell me, right? So the nervous system, basically talk to me, what's wired, wireless? What in the world does that mean?
Endocrine uses the hormones, and nervous system actually has nerves.
Action potentials propagate down the wires.
Yeah, it's like a wired system.
All right. I'll take it.
Chemically done, yes.
So neurotransmitters and hormones. Talk to me. Well, so describe it to me then. Tell me more. Give me some examples.
Neurotransmitters, there's acetylcholine,
Okay. And it's the neurotransmitter for what?
parasympathetic,
Okay. Excellent.
plasminolytic,
Well, tell me hormones now.
testosterone, estrogen are the sexual
Okay.
ones, but there's
That'll, okay.
tons of them.
Yeah. All right. So good. Does that make sense? Okay. Oops. So we'll go back up. All right. So short distances, long distances. Why are we talking there?
The only thing I can think is that the nervous system, it's through the synapse,
Okay.
and they fire, and they're going short distances to get to the next one.
Okay. Yeah. So from the terminal nerve cell to basically to the receptor side of whichever organ. Is that what you're saying?
Yeah,
Okay.
that sounds good.
Okay.
How you said it. And the hormones have to go through your body. They
Okay.
get,
Systemically.
yes.
Yeah.
Well, the nervous is, it's like a defined point. It's from here to here.
Excellent.
Or it's just
Yeah, it's like a
floating.
it's got a
And then
pathway.
I
when
mean,
it
I
gets
just
to
picture
where it's
like the
supposed to be,
synapses in the brain and how it fires, and they're close together.
there's
And
no direct path for hormones. It
Yeah.
kind of float.
Excellent. Very good. All right. And similar, right? So closeness receptor specific. Yeah. All righty. So why rapid? Why is this one rapid versus delayed? Okay.
They have a set path. I mean, they have a set
all those other things.
beginning and ending.
Okay. So what are some reasons why they're delayed, though?
I mean, many reasons. I mean, your
Well, like
body
you saying.
system. I mean, you know,
When the hormone gets released, it's only going to act when the hormone binds to its receptor.
Okay.
So, I mean, the receptor may be
If
in
the
the
receptor
knee
sites
or
are
something.
blocked,
Yeah.
yeah, block receptors or like
or I don't know, with like if,
hypothermic or hyperthermic,
yeah, your body temperature's off or your metabolism's off.
acidosis or alkalosis.
Well, but these are
How-
these statements are kind of assuming everything's normal.
Secretes the hormone.
Okay.
Sometimes the hormone goes through the blood system to where it needs to be.
Right. So there's a longer transport distance. Okay. What else has to happen?
Your brain has to know to release more or
Okay.
to slow down.
Like your pituitary will secrete the initial hormone that may go down to your pancreas.
Okay.
And then the pancreas will release a hormone
This is
that
a reload.
now that has to go to wherever it's going to go. So,
Yeah.
snail mail.
And there's potentially a production delay. Right. So you have to be able to produce the hormone. So if the body's just kind of, we don't necessarily store all the hormones in the amount that we need. You've got to produce it and or release it, and it's got to get enough of it out there to have that effect. So you release one molecule of epi, it's not going to take care, it's not going to support the body. Right? You got to have enough of them systemically above a certain threshold in order for it to have an effect. Make sense? Excellent. Okay. Short versus prolonged.
The nervous system is there for a certain point to whatever the. The nervous system like goes right on my arms really fits. The nervous system.
Okay.
Once it's used for long duration.
Yeah, even like sympathetic. If you need a fight or flight, it's instantaneous. As opposed
It
to
is?
like, well, I mean, within reason, within.
But that's this. Your fight or flight is
But
an
I mean,
endocrine
it's not like
function.
somebody walks in with a gun and starts shooting. We're gonna be like, oh man, it's gonna hit you pretty fast. As compared to like delayed onset, like your growth hormone or something, it's gonna take a while for all this stuff to get.
Okay. So why else is this a prolonged? Why with the endocrine? What's specific with the endocrine that makes it a prolonged? And give me an example.
Talking about like maybe aldosterone, it'll keep going until your blood pressure is raised to an acceptable level. It'll keep releasing it,
But that's a signal. So it has a prolonged. So basically, when it needs to shut off, it takes a while to shut off. That's a prolonged kind of duration, or it has a longer duration of an effect, I guess.
So would
So-
it be kind of like the same way, like it's the chain production to produce the hormone? Would it be the same thing as a chain reaction to stop the production of the hormone? When that
Part of it, but it's also once you reach that, and I guess kind of the example I'd say. So say you pull out in front of an 18-wheeler, right? You just don't after the fact go okay and go on. I mean, for 5 minutes you're sitting there going, right? So you have a prolonged duration because that epi, it stays in circulation until basically there's enough of it that basically gets broken down, or enough of it drops below that threshold to kind of where you kind of calm down. That makes sense? So yeah, so those and that, then the production side of it, so kind of the message is kind of let's slow down is certainly part of it. But basically, these tend to get broken down very quickly. From point A to point B, I send the signal, they go into the neurojunction, and there's chemicals there, or basically other molecules that start to break those components down, right? So acetylcholine gets broken down by acetylcholinesterase there. These endocrines, are the hormones, once those get released, there's not necessarily something in a tight area basically saying, okay, stop, break everybody down. They're in general circulation, and it's going to take a while for enough for those hormones to get broken down. That make sense? Okay. All right. Right, and then which we kind of been talking about, right? So rapid response versus regulation, kind of long-term maintenance. Okay, good. All right, and we talked about this too. So the mechanism of all this stuff kind of makes sense, right? So there's receptor sites, there's neurotransmitters. This makes sense because we talked about this before, I know. So questions on any of this, how drugs function, the pharmacokinetics of all this stuff. Okay. All right, so now we get into this, right? So here's your brain, right? So your brain stem, right? At the top of your brain stem is basically your hypothalamus and then your pituitary glands. Okay. So and here's kind of a close-up of that where you have the hypothalamus and the anterior pituitary and posterior pituitary. Okay. So we're going to start talking about these. Now, basically, the hypothalamus basically kind of controls and tells the anterior and posterior pituitary kind of what to do. There is a slight difference, though, in that, let's see. With the anterior pituitary, if you kind of look here, right? The hypothalamus, so these hormones are actually produced in the hypothalamus, stored in the anterior pituitary, whereas opposed to the posterior pituitary, where they're actually just produced in the posterior pituitary. That makes sense? So if you look there, the anterior pituitary, those drugs are basically produced in the hypothalamus and transported over here to be stored. In the posterior pituitary, they're actually produced and stored in the posterior pituitary. So slight differences, okay, about how they are. Okay. Now, so the posterior pituitary, so where are these produced at?
In the hypothalamus.
In the hypothalamus and stored.
So posterior is in the posterior, right? So everything's done in the posterior. Right? With me? All right. All right. So there's two hormones that we produce, oxytocin and antidiuretic hormone. Okay. Anybody heard of oxytocin? What's the common name that we use? Pitocin. Right? So anybody heard of somebody getting PIT? So when you guys go to labor and delivery, if they actually ever have, if you're induced, most times it's Pitocin that's you're actually given. So you actually basically just, and it's I think it's a synthetic drug. It may actually be through some other animals that they actually collected. But basically it's produced there. It has a couple effects once you get it. So it leads to an increased contraction. Okay? So if you began birth and need some just additional oomph, they can give it to you. Okay? If they want to start induced labor, they can actually give this to you. We typically use it, most EMS providers, because we don't necessarily want to induce labor. Right? We just want to take them to the hospital. But we use it to basically cause the contraction of the uterus. So once the baby's delivered, if they continue to bleed, you give them this drug, it causes the uterus just to contract down. And so basically, as you squeeze down, that's going to stop any bleeding, right? It does a couple other things. Basically, also allows to increase milk letdown. Right? So as you guys are basically learning in labor and delivery, which we'll talk about, is basically there's a couple ways to cause mom to basically, if mom is bleeding, to get them to kind of stop bleeding. One is to actually encourage mom to start breastfeeding, because when it does that, it causes a further release of oxytocin. Okay. All right. The other part of that is that's actually basically antidiuretic hormone. So where have we talked about this? Yeah, so part of the renin-angiotensin-aldosterone system, right? And what did we say it did?
Keeps you from excreting water.
Yeah, right? Yeah, so basically it leads to an increased reabsorption. So basically it concentrates the urine, basically, is ultimately what we're doing, right? So we're basically using this to conserve sodium. When we conserve sodium, or we basically reabsorb sodium, we're basically water's going to follow it, right? Yeah. All right. So those are the ones. Now, interesting kind of, which side note, if you actually want to stop contractions, if you give somebody a bolus of fluid and they stop releasing ADH, they also stop releasing oxytocin. So one of the things when you're at labor and delivery, if they actually have somebody that's in preterm labor and they actually want to stop it, they'll actually just bolus them a liter of fluid. So that's the mechanism how that works. Okay? No, it doesn't. So yeah, they'll pull out some bigger guns, but that's one of the ways that they can certainly try. Now let me actually step up. We don't want to do that. Okay.
Oh no, we might want to. That's kind of gross.
So
You want to do what you
yeah.
Oh,
Yeah.
okay.
Right. That's probably true, right? So it's not medically appropriate to do that, for us to do that. So that, yeah, alrighty, yeah, because basically if they have effaced, if they've dilated and effaced, it's coming and it needs to come. So us going, oh, we want to stop this, right? Yeah. So bad choice. Okay. Now a couple other things. Growth hormone, GH is growth hormone. Basically, it affects most tissues, and kind of go figure. It causes the tissues to kind of grow and proliferate. Alrighty. TSH, thyroid stimulating hormone, basically works on the thyroid, increases the thyroid hormones, and there's two of those. There's T3, T4. So, and we'll talk about those a little bit. Acetocorticotropic, ACTH.
Adrenal corticotropic.
That one. Thank you. Okay. Works on the adrenal cortex. Now, the core, the adrenals actually have a couple different areas. They have the kind of the outer edge and the rim, and they have the core. And those are, they do separate things, and we'll kind of talk about it. But this works on the core, basically increases cortisol secretion, right? So increases just general steroid secretion, all right? Follicle stimulating hormones basically works on the ovaries and the testes, causes the ovaries to basically start the ovulation cycle in the process. On guys, it starts or helps with the development of sperm. Yep. Okay. Luteinizing hormone is the one that actually causes, in females, causes the egg. I'm trying to think of the right. Thank you. Yeah. So it causes the ovulation, so where the egg is released and goes out. In guys, basically, it starts working on releasing of testosterone. Yep. So, all right. And prolactin's another one, basically leads for milk production there. Right? All right. And here's basically a big slide that kind of talks about all of that stuff and kind of what it does. Questions on those? Okay. All right. So there's your thyroid. What's this right here? There you go. That's a cricothyroid membrane, right? Because there's your. Yep. So there's the cricoid ring, your thyroid, and why do we? What's there?
The trachea.
Okay. Yep. Right. So surgical and needle cracks go right there, right? Right. Notice that I don't know if y'all kind of remember, but basically, again, see how vascular this area is. So if you're off, and how the gland is right there. So if you're off, lots of bleeding, lots of bad things can happen. Okay? All right, so the thyroid, what does it do?
It regulates your metabolism.
Yeah, so it's the one that kind of overall does metabolism, and what else does it do? What else does it regulate? Help regulate.
Body temperature.
Certainly, that's kind of part of metabolism, yeah. So it has a different, other than metabolism, what else does it do?
Can you release calcium?
It helps regulate calcium, certainly, yeah. So it helps regulate calcium, right? So what it does, it's basically pyroxidine, and I'm not even going to try to say that, but basically T3, T4, right? This increases the basal metabolic rate, basically kind of your set energy level. So basically somebody that gets, that produces more of this, how would they look? So if we have an overproduction of T3, T4, how is that patient going to present?
Bony?
Okay, so thin.
They can eat meat, no gain weight.
Okay, yeah, so certainly hyperactive. So thin, hyperactive. There would be have increased caloric consumption. Okay. So let's go the opposite way. What happens if they're so kind of they'll have more adipose tissue.
So Graves' disease, isn't that overactive?
They can also get the
Trying to remember. I think we'll get there for sure. Yeah, because we'll get the exophthalmos. I want to say yeah. So well, I think it's coming up. But yeah, I want to say because.
what's the hyperthyroidism, and also get the feeling of a big turkey like
Yeah, what's that called? Goiter. Excellent. Yeah.
And hypo, don't they have like their eyes kind of bulge out of their head? Or they...
Hyper. Yeah. All right, so what else? So somebody else's that's hypo, let's kind of do that. So what else would they complain of?
Being tired all the time.
Yeah, so they're lethargic, they're tired, increased weight gain. What else?
Like jack of all your
Yeah.
right?
So what else did y'all say it helps control though? Yeah, well, let's just do the T3, T4. Temperature, right? So what would they say? Not for hypo. They're cold all the time, right? Hyper is going to be, I'm always kind of hot, I can't cool off, right? So those are the ones that even though it's kind of, most of the other folks are kind of going, it's comfortable in the room, they're going, no, it's cold. All right, and then calcitonin basically causes a decrease in calcium. Basically what it does is it causes and where's calcium stored? In the bones, right? So it causes the bones to kind of start absorbing more calcium. So basically it kind of takes it from circulation and kind of stuffs it into the bones. Okay. All right, so yeah, there's hypothyroidism. And it's kind of hard to see, right? So someone that's hypothyroidism, they're not going to grow as much. They're going to be constantly kind of cold, lethargic, adipose tissue. You kind of start to see there's kind of some. Well, it's hard to kind of see, but there's some swelling around the face. They get kind of a moon-shaped face is a lot of times what they'll say. Okay. There's your goiter. Kind of hard to see, but you can kind of basically see that. Now, what happens here? Typically with someone who develops a goiter, what's happening?
Their thyroid's overactive.
Okay.
Can I get enough iodine in the blood?
It grows to help produce more of the hormones because it thinks that it has
But what nutritional deficiency typically causes that?
Iodine, isn't it?
Yeah, it's a lack of iodine. Where do we get our iodine?
Salt?
Yeah. So typically in second world, first world countries, basically where we have a lot of the food, where we basically just go to the store and get salt, and it's in the salt, we typically don't have problems. Okay? You get the true third world countries where basically they don't get the salt or the nutrients, that's where the goiter tends to occur. And so so that lack of iodine tends to cause, because the iodine is a key component in the production of the thyroid. So the gland basically grows to basically help produce more hormone. Okay, and there's the exophthalmos. You can kind of basically see how our eyes are kind of bulging out. It's not that their eyes actually bulge out; it's that the muscles actually become hyperactive and kind of pull back more. All right, and I guess it's coming at some point when we talk about Graves and all that. Okay. All right, so parathyroid. Where's this?
behind the
Yeah, that's right. So basically on the back of the thyroid, and that's one of the things when they do thyroid surgeries, they have to be careful about getting these because these are, basically that's your thyroid, and you can kind of basically see your parathyroid stuck right there. Yeah. So you basically have to go in there, and obviously the body's not color-coded. So it's a little bit, so they have to be very careful about what they think is truly what it is and how much they cut out. Okay. All right. Parathyroid basically just works to increase calcium. So basically it causes the bones to start releasing calcium. So basically your regulation of calcium is caused by the parathyroid hormone and calcitonin. All right. And there's basically how it talks about calcium, right? So, yeah. So anyway, low blood calcium, you can basically see it stimulates it, and basically just kind of creates all these loops. So anyway, that kind of makes sense. All right. All right, so your pancreas. What's your pancreas do?
Secretes insulin.
Produce bile.
Okay. Bile?
Or the gist of it.
Yeah. So does amylase lipase. Where's bile?
Liver and stored in the liver.
Yeah, produced in the liver, stored in the gallbladder. Excellent. Okay, and bile breaks down. What kind of food?
Protein.
Nope. Nope.
Fats.
Fats. There you go. Yep. So yeah, the proteins and the fats are basically broken down by production of this.
How is that one like? A lot of times I have gallbladder inflammations or attacks after they.
After a fatty meal.
A lot of times you have gallbladder attacks or inflammations after you make a fatty meal.
Is it just because it doesn't have enough production
It-
of bile?
Have enough stored.
Or, I mean, it doesn't have
Yeah, it basically kind of starts to because as you have those, if you have those stones, basically if there's enough fluid in there, basically they kind of float. So you start secreting a bunch of the fluid. Now the stones kind of start rubbing, and they start rubbing against the walls. That's where you have your attack.
And that happens because if you eat a fatty meal, they release all your.
Yeah. Okay. So yeah, so it has the pancreas is one that has exocrine and endocrine. And the endocrine is which ones?
Glucagon.
Excellent. Yep. Okay. Yeah. So bueno. All right. And actually, if you kind of look, this is actually, yeah, that's coming from the gallbladder. That's the duct coming from the gallbladder. So all that. So it actually gets. This is the duodenum. So bile is actually dumped into the duodenum, but it's not produced or stored there. So basically, the tract just kind of comes through there. Okay. All right. So we have alpha cells and beta cells. Alpha cells produce glucagon. Glucagon's function is to do what?
Isn't it?
To stimulate
Release
glucose.
glycogen storage.
Right. So basically, in simplistic terms, right, glucagon causes an increase in glucose,
Correct.
and insulin does the opposite, causes a drop in glucose. All right. How does it cause an increase of glucose? What are some of the mechanisms that works on? How does that
Goes to
do?
the liver and facilitates the glycogen breakdowns.
Okay. Yeah. And glycogen is what?
Stored glucose.
Yeah. So basically, right. So we take a couple of glucose molecules, we stick them together, we call them glycogen. Glucagon causes that to break down. What else does glucagon do?
Does it make you hungry for stuff
Doesn't
to
it
eat?
it decreases the glycogen synthesis and also
So it decreases the glycogen. Say that again?
I don't know. What if that makes sense?
So, but the other thing that it does is it goes through, creates a process called gluconeogenesis, where basically we would grab components. We grab like amino acids, and we grab a couple of like, what else is it? Pyruvic acid's kind of part of that. And make glucose, yeah. So that's gluconeo. So this glucagon causes gluconeogenesis and then causes the breakdown of those. Does that make sense? Okay. Yeah. And then insulin does, how does insulin work?
It increases the reuptake of glucose in your cells. So it can be
Or
used.
binds the glucose and transports it.
Yeah. So basically it's part of that. And what transport mechanism is it?
Facilitator?
Yeah, so it's facilitate transport, right? So glucose is a large molecule. It needs help getting through there. Insulin, in association with potassium, help facilitate its transport through the cell membrane. Make sense? Okay. Yeah. So glucagon, that makes sense, right? So, well, actually, this says let's do this. So,
It's out of the bloodstream into the cell.
correct.
From your cell, you use it.
Correct.
It's not like storing it anymore.
Correct. Well, if you have enough of it, so insulin will also kind of help produce the glycogen. So you take a couple glucose molecules and kind of store it, right? So where do you store glycogen? The liver and
As opposed to
where will you need a sudden burst of energy? Sort of. Be more broad. Yeah, muscles. Yeah. So basically your muscles have glycogen stores and your liver is glycogen stores. Yeah. So when because all of a sudden now we start exercising and the body goes, what are you doing? Start breaking it down. Yeah. Okay. So yeah, so the target's basically typically the liver, but also muscles would be a good one to put there. Insulin is basically systemic. Every cell's got to have that. With the exception of what organ doesn't need insulin?
skin?
The brain. Yep. All right, and then basically, yeah, so here's a process, and you guys can kind of look at this. So here's a process where basically it talks about, all right, so we got too much of it, we're going to decrease it, it becomes normal. We increase again and basically go back through there, or we decrease it, we start inhibiting production, we start making more, and kind of talk about that those circles. Make sense? All right, so your adrenals, right? And you guys said this earlier, right? So they sit up on top of your kidneys, okay? And they do a couple, it's hard to kind of see. All right, so there's a hypothalamus, okay? Anterior, posterior, right? What's produced back here? What's in the posterior? Oxytocin and ADH, right? So everything else is basically up here. So, right, so we do the AC, adrenal, how do you say that, Doug?
Adrenal corticotropic hormone?
That one. Right, so it goes down to the adrenal, right? So then you can kind of see there's the cortex, okay, and the medulla, right? And so basically those cause an increase of blood glucose and protein metabolism, okay? Other stuff that basically affects the adrenals is basically ADH, right? And basically what's this one, what's the glucocorticoid that we talked about earlier? Or I'm sorry, it's a mineral corticoid, but yes, aldosterone. Right, so there's mineral corticoids and glucocorticoids. Right, so the glucocorticoids kind of help regulate glucose. The mineral corticoids help regulate minerals. Okay. Now the other part, basically the core of this, basically that's where epi and norepi are stored and produced. Right. So basically we come down through the spinal cord here. There's a part that goes off that, as long as everything's functioning, that basically stimulates that core to produce and release epi and norepi. Yeah, and which we kind of talked about this, right? So the receptor sites of these are what? Yeah, alpha 1, beta 1, alpha 2, beta 2. Yep, right. Right. So blood vessels, the heart, the liver. So why the liver?
To release the glucose?
Yeah, so stimulate the breakdown of glycogen. Yep, yep. Excellent. Alrighty, so let's see. Oops. So that was the medulla, yeah. So the cortex, aldosterone works on the kidney. You guys talked about that, right? So that's part of the renin-angiotensin aldosterone. Okay. Cortisol basically works with glucose and inflammation processes. Right? So basically these are steroids. Well, that kind of makes sense? Excellent. All right, so anterior pituitary. So basically growth hormone. So if you don't have enough growth hormone, basically it leads to dwarfism. Kind of makes sense, right? All right. So now if they don't have enough, basically there's treatment now. So as long as it's identified and the treatment's available, they basically can, there's some drugs that'll basically stimulate these or act as growth hormones. Right? You have excessive growth hormones, you get giganticism. So right, so the guys that are, 10 foot whatever, so the folks that get in the Guinness Book of World Records have these problems. Acromegaly is similar, but acromegaly basically just kind of deals with the hands and the face. Okay. With those, typically, it's if there's a tumor that's causing it, they can remove the tumor. If not, then basically they can give some medicines that basically inhibit its function.
Like those that protropin and all that, is that what like the baseball players take, the human growth hormone, hormones for like?
I couldn't tell you for sure. But yeah, that would kind of make sense. So posterior pituitary, right? So you guys talked about oxytocin, ADH. Okay. If we don't have ADH, basically you get diabetes insipidus. What's diabetes insipidus?
You basically just urinate nonstop.
So what's the typical diabetes that we talk about? What's that called? Yeah, diabetes mellitus. Okay. Diabetes insipidus. Basically, how they figured out and where the diabetes comes from is basically it's an increase in urine. So the diabetes mellitus is a sweet urine. And so that's kind of what diabetes mellitus means. Diabetes insipidus is basically just lots of urine. Okay. And then we have nocturnal enuresis is another part of that. Right? So just lots of having to constantly wake up at night. So the vasopressin, y'all heard of this? Where have y'all heard of that?
On the truck.
Okay. Yeah. What's it used for?
Raising blood pressure. Or
yeah. Right. The thought is because basically it's a vasoconstrictor. Typically, where we use it, it's in cardiac arrest. So ADH basically has a very potent vasoconstrictive property. We're not necessarily using it for the antidiuretic hormone, but certainly that's part of what it is. So someone that's got diabetes insipidus can basically get that as part of their treatment.
When they say pressing, usually they're talking about, is that what they're talking about?
It's a vasoconstrictor, yeah. Okay. Yeah. So there's a couple others. So basically, if they're missing those hormones, then they can basically get those replaced. The parathyroid. What's the parathyroid? What's the one thing it does?
Calcium reuptake or release calcium.
Yeah. Okay. So you don't have inadequate calcium levels. Basically, start taking more, right? Okay. Excessive calcium. Basically, surgically remove the excess the tumor, basically. Make sense? Okay. So your thyroidism, right? So if you have hypothyroidism, so folks that get diagnosed with hypothyroidism, and this is kind of one of those, you really kind of have to think about it and pay attention, or the physicians have to kind of really thinking about it. But, folks that kind of go in there, well, I'm constantly tired, I'm overweight, and, so a lot of folks kind of say, well, start exercising, but you kind of have to put it all together. I'm cold, I'm overweight, I don't have energy, I'd like to exercise, but I just don't have the energy. And so if they do, if enough process goes through there, they need to kind of start thinking maybe they're hypothyroid because they can start replacing the synthroid.
And that condition, you're saying would be cold?
Yes, those, yeah. So, right. So yeah, it's a very, the metabolic rate's lower, because it's lower metabolic rate, they're not generating as much heat. Hyperthyroidism basically is the excess removal, but typically most folks basically don't overdose on Synthroid, although you potentially could, right? But there's thyroid toxicosis, which is basically a thyroid storm, or basically there's just overstimulation of the thyroid, because remember the thyroid glands kind of basically, you're getting some stimulation from the pituitary glands. PTU basically is a chemical that folks can take that basically causes this thyroid to kind of start increasing production. So folks that are overly sensitive to PTU, and if you kind of look at a lot of the food products, it's on the bottle that, hey, this contains PTU. Or actually they say propylethylene, yeah, uracil anyway. All right, so yeah, ACTH hypersecretion basically is the Cushing's. Right. Hyposecretions is Addison's. And did y'all talk about that in pathophys?
About Cushing?
Yeah,
Like,
Cushing's and Addison's.
Very. I think we were talking about like lesions. They were talking about like Cushing's and the red face and all that.
Okay. Yeah, I guess it's third semester you talk more about it. Okay. But yeah, so basically again, you can get into hypersecretion, hyposecretion. Again, kind of go back, if you understand what the hormones do and what section they're controlling, right? So these basically control the cortex, which is basically the mineralocorticoids and the glucocorticoids. You have an overproduction of those. We got too much glucose and too much minerals, and so basically they're going to have those effects. Underproduction is basically everything's going to kind of slow down, right?
So all your corticosteroids and stuff like that, that's produced through there?
Yeah. Right. So yeah, so basically you don't underproduce it. You can get therapy to basically stimulate those and produce them. Overproduction, one of the big things is basically we're dealing with hypertensive issues. All righty, so the pancreas. All right, so let's see here. The pancreas, insulin, actually, we kind of talked about this, right? So insulin reduces blood potassium. Because remember what I said earlier? So insulin, we need, in order for the glucose to get across, you need insulin and potassium. So insulin, potassium, and glucose, basically the insulin and potassium go inside the cell as well. Those are gone. They get kind of broken down. Y'all kind of, and I think y'all were talking about earlier about asking about why you would give glucose for somebody that's hyperkalemic. Well, it's not so much the glucose that you're giving; it's you're giving the glucose in order to give the insulin because you want to drop the potassium.
So if someone's not a diabetic, you can still give them glucose to promote this and that their body's producing?
Well, even if they're diabetic. Yeah, so you're hyperkalemic. So for whatever reason you took in too much, or you're basically your body has too much potassium.
Inside the cells.
Right.
Okay.
Well, actually in circulation, because inside the cells we don't care because it's not effective. Outside the cell it has bad effects. So yeah, so you got too much, because that's basically how we measure it. I can't tell you how much is in your total body circulation of potassium. I can tell you what's floating in your bloodstream. So basically, because we can draw that out, we can basically do a drug lab test and basically analyze it. I can't. There's not a way for me to correlate that number to what's inside your cells. Okay. But yeah, so even say you're a diabetic, okay. I'm going to give you glucose and then turn around and give you insulin to hide the potassium. All we're doing is taking the potassium and sweeping it under the rug. But when it gets under the rug, I don't see it, and I'm happy for a short period of time. So it's a temporary measure. The long-term effect, or the long-term treatment, is then basically to give them K-exolate, which basically will grab the potassium and get rid of it, and then ultimately, as it really drops the levels, it'll start coming back out of the cells as needed.
Well, that's for excess potassium?
Yes.
But doesn't aldosterone do that? I mean, isn't it secreted when you have too much potassium? Isn't it like too little sodium or too much potassium?
Yeah, because the sodium works with the, yeah, because if you
It's
reabsorb
in
sodium, you're getting rid of
conjunction
potassium. Yeah. Okay. Right, so that kind of makes sense. So we give insulin to reduce blood potassium. You also give glucose or insulin actually, that doesn't make sense.
Didn't it go the other way?
Yeah.
Then blood glucose, increase insulin.
Insulin should lower blood glucose levels, so I'm not sure. So that makes sense. So see that's wrong? I'm trying to figure out what the thought is here.
Point the other way.
Yeah.
Blood glucose.
Yeah.
Insulin.
Yeah. And glucagon does what?
Increase
Yeah.
blood
Glucagon should increase blood glucose levels.
Go backwards.
Okay. Beta blockers, and we'll talk about beta blockers in a little bit, but beta blockers, basically glucagon. See, why is this working backwards?
Well, it's like, it seems like they got the plus and the minus sign flipped around.
Well, I can see that, but this one, beta blockers don't have an effect on glucagon. Glucagon has an effect on, actually, no. Well, we'll talk about this. But basically, beta blockers and glucagon have a kind of an interesting little tidbit. When you give, you can actually give, so folks that have overdosed on beta blockers, you can actually give, so we can't necessarily give, or I guess you could, systemically give basically a beta agonist. The problem with giving a beta agonist is that you kind of whop the heart. Okay? So it's kind of like calcium. If you don't have a calcium channel overdose, basically the treatment is, well, here, have some calcium. So you can basically kind of do that with patients with beta blocker overdoses. The problem is we don't necessarily have systemic. The only beta agonists that we have are typically the ones that we give for nebulized medications. So we can certainly do that. But another way, because a lot of folks will actually carry glucagon, how the beta receptors work basically causes a secondary messenger to occur. Y'all kind of remember how with cells, basically there's one of two methods, either that has a direct, when you stimulate a receptor site, it either has a direct result or an indirect result, basically through a secondary messenger. Y'all kind of remember that? Okay. That secondary messenger, that glucagon, or basically glucagon uses a secondary messenger that causes the same effect as if you were stimulating the beta receptor site. So by giving somebody an injection of glucagon, so basically you can give glucagon IM, and it will basically cause an increase in their heart rate. So somebody overdosed on beta blockers and they're hypotensive, and their heart rate's low, and they're bradycardic. Basically, you can give an injection of that, and that's going to increase their heart rate, which then increases their cardiac output. That makes sense? And it just works through a secondary messenger. Okay. All right. So insulin. And there's several forms of insulin. I remember years ago with my grandma, she had insulin. She was an insulin-dependent diabetic. Every meal, so this was 40 years ago, so every meal she had, she sat down and gave herself an injection. Because basically the insulin that they had back then was basically very kind of short-term. Over the years, they basically kind of developed some short-acting insulin, some middle period, basically long-acting insulin. So now a lot of folks can basically get one shot, and it's a combination of short-acting and long-acting insulin, so where they can basically regulate their insulin all day long just with one shot. So now they still have to kind of watch what they eat. Now there's even stuff better, because basically now you have an insulin pump. And so you can basically kind of adjust how much insulin, because it's constantly producing that insulin. Or not producing it, but releasing it. Okay. So basically there's regular insulin, which is kind of what the natural insulin, and then they have the modified stuff, which is basically where they add stuff to the insulin, where the body then has to break it down. It's kind of like extended release medications. You know, you have to basically, your liver has to metabolize enough of it, and it takes a certain amount of time for that metabolism to occur in order to kind of then release it later on, or have it available later on. All right. Now, oral hypoglycemic agents, and there's a couple things. So when you have, and actually let's do this. So tell me about diabetes. What do you know about diabetes?
Well, your body either produces too much insulin, or not enough insulin,
Okay.
so your sugar gets high, or you don't produce enough, and your blood sugar gets low, or you don't eat enough, I guess, your body doesn't, or it's too slow.
Yeah. So let's do this. So
Hyperglycemic.
type 1 is,
No, insulin.
yeah, so zero, very limited insulin production, nowhere near enough. Okay, typically is called
Insulin.
juvenile onset diabetes. Excellent. All right, so those folks tend to kind of, in a lot of cases, what they're kind of thinking is that there's a virus or they have some sort of autoimmune disorder, or they get a virus that causes or leads to an autoimmune disorder that basically kind of drops the production of it, basically damages the cell. Okay. Type 2 is,
Where that doesn't have an affinity for sugar, right?
yeah, a couple things. Either it's able, your body's able to produce it, it just doesn't produce enough of it, and or what is produced doesn't function as well. Okay. So basically, you can have folks that develop adult onset diabetes or type 2 diabetes that ultimately become insulin dependent diabetics. It just depends on how much more the pancreas gets damaged and what works. Okay. Those that basically have the type 2 diabetes, which is kind of the where they get the oral hypoglycemics, because you can basically have folks that are diabetics that basically take oral medications to help control it, and those work in a couple ways. And you'll hear these. Those will, sulfonylureals, alpha glucose inhibitors, those thiazole. And which y'all heard of, like, so glucotrol, diabetase, glyburide, okay, micronase, metformin, glucophage, okay. So basically, they're different categories of drugs depending upon kind of what they think is kind of going on. Okay? So basically, like these basically cause an increase secretion. So these basically stimulate the pancreas to produce more. Okay. The biguanonides basically increase glucose uptake and decrease glucose synthesis. Actually, that doesn't make sense. Decreased glucose synthesis. I bet it's going to be increased glucose synthesis. I bet it's the other way. Increased glucose synthesis and decreased glucose uptake, because you want more glucose.
I'm stuck on that one. Hypoglycemic. Hypoglycemic is going to decrease, or because you have a decrease in sugar. So these are sugar. See what I'm saying?
No, but these are basically going to lower your sugar, right? So with diabetes mellitus, you ultimately have too much glucose systemically. It's not in the cells.
So shouldn't, like, they're anti-hypo.
So you're saying you take these things orally
To decrease your glucose levels.
and the first
Okay, never
ones,
mind.
they increase insulin secretions.
Right. Because the problem,
Anti-hyperglycemic.
having too much glucose isn't necessarily the problem. The problem is the glucose isn't in the cells. So our whole goal is to decrease glucose levels because we want the glucose in the cells.
So the glucose neosynthesis, that's what it's talking about. It's going to decrease the production of sugar, right? Glucose synthesis.
Yeah, you're right.
So
Okay.
yeah, then that's
Yep.
right. And increase glucose
Goes uptake.
in your
Okay.
blood
Uptake in the
or
cells.
whatever.
Okay. That makes
So
sense.
it's decreased glucose production, but it's
Increasing
also
the
increasing the uptake into
Yep.
the cells.
And then these basically cause an increase in effectiveness of the insulin, right? So if you kind of look, so there's kind of different ways that they can kind of attack, because depending on how your insulin's produced and what it's doing as to how they kind of achieve the treatment.
So like the very bottom there, the increased insulin effectiveness, that could
Okay.
be like for a type 2 diabetic who's still
Right.
producing
Well,
insulin.
all of these, basically all the oral agents are for type 2 diabetics. So they have to be able to produce, they're producing some insulin, just not enough. And or their insulin is not as effective. So since their insulin is not as effective, so that like that increases the effectiveness, that increases the effectiveness of it. Okay. These basically increase the secretions, and those delay carbohydrate metabolism basically affect the breakdown. I'm not exactly sure how those work, but yeah, I'm not sure how those works. Does that make sense?
When carbohydrates are broken down, they're broken down into sugars.
Right.
So if you delay that, then you're not as much glucose.
Yeah, but I'll have to go look up. Let me go look those up and see, because it's typically related to well, I guess if you're actually overproducing glucose, that would be ultimately bad too. Yeah, let me go. I'll have to go look those up and see. All right. So basically, hyperglycemic agents, basically agents that increase the levels of glucose, right? D50, glucagon. And glucagon is going to lead to increased gluconeogenesis, which was what?
Which takes
Creation of
control
glucose.
the muscles and breaks down glycogen storage in the liver.
Well, right. So it does. So it does break down glycogen stores in the liver and in this. But gluconeogenesis basically means what?
Takes amino acids.
You build new glucose.
Right. So we're building glucose molecules.
So what I just said doesn't happen?
No, but I was trying to get you to say. I was trying to. So what you said is not gluconeogenesis.
But I
So you're correct. Glycogen or glucagon does break down glycogen.
But it also builds
Correct.
glucose.
Correct. Yep. Yeah, and then this basically inhibits insulin release. You don't release insulin, then it's going to raise your blood sugar levels. Okay. All right. Estrogen, progesterone. Right. So basically, hormones to control the female reproductive cycle. Right. There's kind of debate whether you should get estrogen replacement therapy. Yes or no. There's some cases where it's saying basically it increases breast cancer. So still kind of a debate. So you may see some folks that are on it, some folks that aren't. Yeah. All right. Now, another part of that, basically the oral contraceptives, in essence, those still basically work on the estrogen and progesterone. These basically the oral contraceptives are basically controlling the levels of estrogen and progesterone. Because when you have a spike in progesterone, that causes, or basically that's the follicle-stimulating hormones and the luteinizing hormones basically causes spikes in estrogen and progesterone, which cause different things. These basically maintain those levels to where they don't spike and change. Yeah. One of the big things, though, and always kind of why we always kind of ask folks, basically that the oral contraceptives have one of the nasty little side effects is that they increase embolisms. All right, uterine stimulants, right? So oxalytics basically induce labor, so we kind of talked about that. Postpartum hemorrhaging, we talked about that. Okay. Tocolytics are basically those that relax the muscle. So basically if we want to stop contractions, yeah, you basically give beta-2 agonists, or what was the other thing we could say we would try? Fluid. Okay. All right. And then, yeah, there's basically some infertility medications that are out there, male reproductive agents, yeah, BPH, benign prostatic hypertrophy. So guys can get a hypertrophic prostate, leads to basically, actually, everybody's, sorry, you're going to get it. It's just time. But yeah, basically once they kind of get older, there's basically medications to help kind of control that, and or they go in there and surgically fix stuff. Let's see. Yeah, and then basically there's other, right, so all the erectile dysfunction medications. Okay. So are these only for guys? No. Right. So make sure you ask both male and female about if you're starting to give nitro, you need to kind of start asking about erectile dysfunction or medications. All right, break.